Okay, Octavian, I give you the rights to start broadcasting your screen. Okay, go ahead, please.
Okay, just a second. So, okay. Hello to all of you. Welcome to this webinar. I'm very happy to be part of it. And today we will start to talk about treatment plan. First of all, let's ask what's the sense of a treatment planning. The sense of a treatment planning is to satisfy the patient and to avoid mistakes. And to do this, we have to look about a lot of things to avoid this kind of weird things. And this picture you see he made a reposition of two teeth. Here it's I don't know how can I say it, but for my opinion it's a surgical hyperactivity without any treatment plan. So let's start with the treatment planning. Treatment planning. We have always straightforward, advanced, complex cases. So at the same time, we will have straightforward, advanced, complex treatment plans. But in the first point, there is a discussion with the patient, which is very important because we always have to hear what the patient wants. Then, continuing, we need X-ray and CBCT nowadays. Study models, of course. I don't want to talk now about each point. I just mentioned them, and then at the end maybe we talk about them when I showed my case or the other participant showed their cases. Okay, so study models anamnesis. This is the first part of a treatment plan, and these are all the things we need. Then we start with the different treatment plans. Preliminary treatments like fillings and all this stuff. Surgical treatment plan. Ortho treatment plan. Prosthetics treatment plans. So as you see, we have a lot of different treatment plans. Endo treatment plan, or perio treatment plans. Then every treatment plan, if it's surgical, endo, prosthetic, has its own protocols. So as you see already, we widen up the all the cases. So if we have a complex case, we will have a surgical treatment plan with a special treatment protocol and so forth. And at the end, of course, we have to do the timetable of the treatment sequences, because what is the reason of a treatment plan? We should plan everything in this way, short time, as much as possible, then as much as possible.
And then I'll be back to sort them all. Oh, just this thing. Sorry. Well, there's my private stuff, right?
The factors having a treatment plan. First one is patient demands. Then we have to tell the patient the number of possible solutions. And of course, we have to be sure about the capability to realize the chosen treatment. And at the end, the financial capabilities of the patient. It's a very important point, which makes us possible to choose between the different solutions. So, this was my introduction, and this is my case. And this is the case I want to discuss about it. One information, the patient wants a complete makeover to restore the old restorations, and money is not important. So when you try to make a treatment plan now for this case, don't think about money, and try to make the steps we needed. So the treatment plans in every direction, if it's prosthetic, surgery, or whatever. So thank you very much listening to me, and we will start later to discuss it. At the end, I will show you my solution. Thank you very much. Now, is someone here? Nikolaus? Nikolaus? Nikolaus?
Ja, ich bin hier, sorry.
Hello?
Ja.
Yeah?
Your question.
In the beginning of the webinar, you said something about anamnesis. I'm not familiar with the term. Would you tell me what it is?
Yes, anamnesis is when you ask the patients about all his diseases, when you check out if all the things are interesting before creating a treatment plan. This means if he has some caries to be fixed before starting, if he needs hygiene. This means anamnesis, and especially what kind of diseases he has, so you can plan your treatment in the right way.
Okay, thank you.
Okay. So, what about Mr. Hutchinson, George Freedman?
I think that the planning for the case makes a lot of sense, and the process is good, and I'm eager to see how it's going to play out in the particular case.
Ian?
I must admit I had problems with the sound. So when I look at this case, I'm looking at that canine. Are you thinking of bringing it down into occlusion?
No, this was not my solution.
Right.
This was not my solution. You will see it why.
Well, I'm an orthodontist, so if I see something in the wrong place, I want to move it.
Would you move such a canine?
Yeah, I mean, you could section the bridge, distalize the premolar, and use a mini screw temporary anchorage device to bring the canine down, which would mean one less space.
Well, you're partly right. I show you then why.
Okay.
Okay, then go ahead. Any more questions from the audience?
I would like maybe later on.
Okay.
If someone would like to try to make a treatment plan on this.
Good. Then go ahead. Obviously, there are no questions right now. Then show us, please, your solution.
Okay. So start. So just a second. Okay. So this was the final result. Of course, single crowns. In this picture, the treatment isn't ready by now. This is a picture where I made on both sides sinus lift because otherwise I couldn't put the implants. I retracted the premolar like Ian said already, but I extracted the canine because it has a curved root and it was in a quite a bad position palatal. And it was for the patient a lot easier, a lot less invasive. And so at the end, the root canals here at the, here you can see it, at the 7th tooth were done. Every tooth got a single crown. And now here I show you a sequence. This was the auto I did. So, but the trick is because the patients didn't want a complete auto, and he didn't want to have a space between the teeth when I do the auto. So what have I done? I cut it, the bridge in the middle,
Yeah.
and tiered it slowly back. And during this procedure, I always put a little bit of composite on the side of the lateral incisor. And so at the end, I arrived at this result. So here, just a few sequences about the first session when I put the brackets on and I took out the canine. You see the position was quite bad, and the root of the canine, when I took it out, it was like an L. So I think it would have been quite impossible to put him on the right, on his right place.
No, no, no.
Okay, no. Well, I
Curvy roots are okay.
anyhow, the solution worked very well here, filling up with bone grafting material, BIOS. It's the material I prefer because it's it has the best result for me, and covering it with a piece of a membrane. Compression about 2 minutes at the end, and then suturing. So this was my case. I think it was a quite interesting case because it touched ortho, it touched endo, it touched prosthetics, surgery, and of course hygiene.
Okay. So, please, your opinions and start discuss.
Well, it just depends on the patient, doesn't it, I suppose. Orthodontically, you could bring that tooth down, like I say, using mini screws, but it would lengthen the treatment considerably. So, you know, you have to give options, and extraction is a fair option.
Yeah, no, you know, that's what I said in the introduction. You always have to hear what the patient.
Yeah. I mean, the other alternative, if they didn't want implants, would be to orthodontically close all the spaces, but you would need mini screws to do that.
And how long would it take?
Exactly, a good 18 months, possibly 2 years. And most patients won't accept, or adult patients won't accept that.
Right.
Not when you can place implants. So you've got to tailor the treatment plan to suit the patient.
You know, here in Romania, it's probably very good orthodontic doctor. So the orthodontics I do are quite simple, and you have to find a solution. This is awesome.
Yeah, it's a balance at the end of the day.
Yes, of course.
George?
Well, I don't do any orthodontics myself, so I'll leave those comments to the side, but I was impressed by the positioning and the planning of the implants, which will make the restorative portion of the treatment very predictable and really very straightforward. So I like that, and even though we haven't seen final visual of the mouth after the completion of treatment, I suspect that it's going to turn out very well.
Yeah, thank you very much. No, it should be okay because I didn't saw him since 1.5 years now. In the beginning, he came every 4 months. Now he didn't come for 1.5 years.
Okay. There are questions from the audience. I start in order of appearance. Maureen, can you hear me?
Yes, I can hear you.
Okay, fantastic.
I have a couple of questions. My first question is, did you use piezo surgery saw to remove the canine? Number one, because I could see the saw's end, so I think it was piezo. Number two, I want to know, how long did you wait before providing implant on the canine region after you had extracted the canine and after you had grafted with BioOS? How long did you wait to provide implants to the patient after the surgery and after the bone grafting?
Okay, first question. Yes, I'm a fan of piezo. Even if it takes a little bit longer, it's a lot less invasive. And second question, I usually wait after grafting 3 months to put an implant, and then wait another 3 or 4 months depending on the bone consistency.
So you use the piezo only for the bone. If you had to section the crown of the canine, or if you had to section the tooth to take it out, would you have used piezo as well, or would you have used the rotary drill?
No, normally I use piezo, but sometimes I have to use even a burr. It depends on the situation, but mostly I'm using piezo, and I have very good results. But I'm not using piezo only for extraction or bone cutting or whatever. Piezo for me, especially when I'm making immediate implants, I'm using it for cleaning the alveolar, and it guarantees me a very clean site. I have a special tip which is diamond with diamonds, and it cleans it very well. It refreshes the bone, and ultrasonic waves normally kill bacteria at the same time. Of course, always using at least the loop.
Okay, thank you so much. This was very helpful that you use the piezo surgery for cleaning the alveolus of the implant, of the tooth in which you want to place an immediate implant. Thank you.
Welcome.
Thank you very much, Maureen, for your value-adding question. The next question is from Samar Esavi. Samar, can you hear me? Obviously, you don't have a microphone. So I go through your question. No, she can't. The question is, if the PT refused the surgical removal of canine, can I left it?
Yes, but what is the solution then?
Well, that's pretty.
Of course, you can always leave if there is an impacted tooth without any signs of problems, cysts or something like that. You can leave it.
Okay.
But what would be the solution if you leave it?
Okay. Okay. Good. So, are there any other questions from the audience? Jörg, do you have a question, possibly? Jörg?
No, I have no question, but I have no huge cases in my studio.
Okay.
But it's very impressive to see this solution.
Okay. Thank you.
Idea. Okay, yeah. Thank you.
Gaurav, do you have a question? Gaurav? Okay, good. Now I would love to switch to George Freedman. George, will you make your case ready? I entitle you to speak now, and I also switch to your screen. I'll make you a presenter now. Okay?
It is. I'm ready. Let me know when.
Now.
My screen. Yeah. Okay. Can you see my screen?
Yes, perfectly.
Good. All right. What we're looking at this DoooX roundtable, from my perspective, is treatment planning, and I've chosen the posterior resin bridge. Interestingly enough, this is a procedure that we no longer use. The reason that I chose it is because we can show not only the treatment planning beforehand, but also the result of the treatment planning 10, 15 years afterwards. Now, I'm not going to go over the various treatment planning points that were made by Dr. Fagaras, because those are all important and they should all be done. I've taken those out, and I'm simply going over the clinical conditions that help me to make my decisions. We start off with the oral condition. Is it healthy or poor? Just because somebody has poor oral health and isn't taking care of their mouth doesn't always mean that we can refuse them treatment or that we want to refuse them treatment. Often, many of our patients, in fact, probably between 85 and 90% of them have less than ideal oral health. Do these people not get oral care, or do we adapt and modify our care into these directions? Now, if we take a look at treatment objectives, and this is what goes into my treatment planning, these are the most important factors. We want to restore function to the patient. We want to restore aesthetics. Why are aesthetics so important? Because patients aren't willing to spend money on function. They will spend money on aesthetics. They will be interested in aesthetics. Function is usually a secondary or tertiary matter for most people. And something that is very important to me and to the patient, although they don't realize it, is the maximum conservation of tooth structure. Given this, let's take a look at how it affects our treatment planning. First of all, what treatments are available? These are dependent on the time that we're doing the treatment and on the location. Not all treatments are equally available everywhere in the world. Similarly with materials. Materials improve all the time, and it's easy to criticize treatment planning that was done 10, 20 years ago because they didn't use today's materials. But we have to remember that today's materials were not available at that time. One area that often gets overlooked by the dental professional in treatment planning is the ease of maintenance. How easy is it for the patient to maintain the case once it's been placed in the mouth. And this is important because while we may see the patient 2, 3, 4 times a year, the patient is with his or her mouth 365 days of the year. So if they're not going to take care of that, whatever we do is going to fail. The ease of restoration is very important as well. The ease and the practicality, we should say, of restoration, because sometimes we bend over backwards. We will do heroic dentistry to save a tooth endodontically that is destroyed subgingivally, and no matter how good our work is, we find within 12 or 18 months that the restoration is failing, not because of our dentistry, which was heroic and perfect, not because even of the patient's maintenance, which might be very positive, but simply because the condition did not lend itself to that kind of restoration. And then we come back to something that I consider, again, very important, the maximum conservation of tooth structure. So, before I actually start these cases, I'll mention that they were done about 10 to 15 years ago. And the reason I like to look at them is because they're still functioning effectively in the respective mouths that you're going to see. In effect, what we did was planned as it was, and it was successful, which gives us a good idea of something that we're going to look for and the factors that will make our treatment planning successful in the long run. Now, our first patient is a young patient with good oral hygiene, and they're missing a first bicuspid. First bicuspids, in the days of amalgam, were often lost because a large MOD amalgam would often leave the lingual cusp weak. A good strong bite or some hard food would break the lingual cusp off, often subgingivally, and cause the tooth to be lost. In this case, we have pretty well ideal conditions, very good oral hygiene, great bone, and today I wouldn't even think of a bridge. Today, with today's materials, today's knowledge, my first and only reaction here and only presentation to the patient would be a single tooth implant. But this was 15 years ago when the implant procedure was not yet quite as predictable as it is today. So we have ideal orientation of the teeth. Everything is pretty well the way we would like it. If we take a look at the second bicuspid, it's intact, a healthy tooth. If we take a look at the cuspid, it's a healthy tooth. The last thing I want to do is to cut these two teeth, the second bicuspid and the canine, into or down for full crown preparation. These are healthy teeth, and I'd feel horrible about destroying all that healthy tooth structure. So I compromise. What I'm going to do is I'm going to cut little retention grooves in these areas on the lingual of the cuspid and on the occlusal and mesial of the second bicuspid as retention for a resin-retained bridge. Now, a lot of the resin-retained bridges failed, and the reasons that they failed was that either the span was too long, beyond the capacity of the material to withstand it, or the preparation, the retention areas, was not extensive enough. It was too constricted at one point and caused a fracture. And the anatomy of the space was not direct enough or parallel enough to allow physical retention of the restoration, and that the contacts between the pontic and the retention arms was not large enough. So having had those failures behind me, I was able to do something that I felt would hold. Here we have the impression of the preparation. The preparation can be made under local anesthetic, of course, and shouldn't be a problem. Here's the provisionalization. Provisionalization can be made with any material that, not the standard BIS GMA, but the expanding ones that will take up the space and stay there. They're not great provisional materials, but they do stay in place for a week or two until the laboratory sends back its bridge. And here's the bridge. You can see the pontic. Pontic is nicely colored for an aesthetic restoration, and underneath the composite, you can see the actual wire. This is a composite wire that has been inserted to increase the strength of the bridge and the strength of the retention. It's a fairly rigid material, especially once it's cured, and it's going to sit very well. Here you see the pontic on the model. You can see how it fits in from the buckle perspective and how the aesthetics will match with the existing occlusion. The occlusal of the restoration showing characterization to match the existing teeth, including the characterization on the occlusals of the second bicuspid right over here. Now here you see a close-up of the retention arm on the distal, and you can see that the area, the contact area between the pontic and the retention arm is as large, deep, and wide as we can possibly make it. Here's the try-in into the mouth before the cementation, just to make sure everything fits. It should slip in easily and without any tension. And here is the cemented restoration from far away. Initially, after cementation, the shape of the crown from the occlusal, or the pontic rather, is a little bit different than it would be naturally, but we're looking to fill the space effectively. And here you see from a closer perspective, and you can see where the contacts were being verified. We've lost most of the characterization on the second bicuspid. We've retained the characterization on the occlusal of the pontic. And here is the contact area. You can see how wide the contact area is buccolingually, and you saw before how deep it was occlusogingivally. And here's the contact area to the cuspid, a little bit smaller because now we're dealing with a change of angulation as well as a contact, but nevertheless quite wide buccolingually. This is a little bit inaccurate anatomically and will be corrected. Here you see the before, and here you see the after. Notice that the contact area between the pontic and the retention tooth are as deep occlusogingivally as realistically possible. The tissue will grow around the pontic and create an ovate pontic quite naturally. And here again you see the contact areas and the contact areas from the occlusal and from the buccal. Now we have an older patient who's got poor oral hygiene. How poor is the oral hygiene? Well, see for yourself. This is not an ideal case, and quite frankly, the oral hygiene is not going to improve. Most of these teeth are going to be lost. There are a few teeth over here that are on the lower arch that are relatively good. One has a periodontal infection. This is the first bicuspid beyond the apex, so that tooth is not savable. You can see the periodontal infection over here. It's suppurant. Any pressure on the gingiva over here gets pus flowing out. But the bone on the second bicuspid and the cuspid are relatively healthy. And here you see the picture from the occlusal. Surprisingly, the patient is a physician. And one of his conditions is he wants treatment, but no treatment which will leave him without a tooth in a very visible area of his mouth. You can see the periodontal problems both buccally and lingually, and here's a close-up of the tooth. And you can see it right over here. Now, here you see it from the buccal, and what is the treatment going to be? Well, what I do here is I create the retention grooves on the cuspid and on the second bicuspid, the retention areas, without removing the tooth that's going to be the pontic, without removing the tooth that's going to be lost. I take the impression of it and send it off to the lab for the bridge. They, of course, have to remove the tooth that's going to be lost, and you can see a close-up of the retention area as wide as possible. I'm not worried about the thin lingual cusp or area because this is going to be held together with adhesion, and there's not going to be any pressure against it. Same on the cuspid area over here. So you can see these are class 2 type retention areas to give it not only buccolingual retention but also occlusogingival retention. Here you see the provisionals on those two teeth, and again, they're relatively poorly fitting, but they don't have to be good. A week later, the patient comes in, and his diet has stained those bright yellow, which often occurs. I usually warn the patient about that. Not a problem. Here is the bridge that we've received back from the laboratory, and you can see the hard material that is used to provide the bridging underneath the composite over here that is used to provide the aesthetics. And here you see it from the occlusal. Again, the same idea as we had before. A try-in onto the teeth. Well, don't forget that the tooth that was going to become the pontic was still in there, so we actually removed that tooth in order to control the bleeding from the socket, so it wouldn't interfere with the cementation. We put on a rubber dam, and then we clean out the surfaces, put our bonding agent. This is a dual cure bonding agent. No matter how much you put the light through a millimeter or 2 millimeters of composite, it will not get through and polymerize. And we put the cement in. It's, again, a dual cure resin cement. Clean out underneath with floss to make sure there's no floss underneath the pontic. And it's nice and smooth as it was crafted to be. And this area over here on the lingual, mesiolingual of the second bicuspid will be polished a little bit afterwards. And the rubber dam is removed. You can see the immediate socket of the tooth that has just been extracted, and you can see that this area has been polished on the mesiolingual. Now, as the healing of the tissue occurs, it will heal around the pontic and create a nice ovate pontic, which is easy to maintain and easy to for the patient to keep clean, at least as easily as I could possibly make it. This is not an ideal solution. 15 years later, although the patient still has this. He's lost most of the other teeth that he has in the mouth, but this bridge still remains. Notice on the occlusal over here, if we go back one step, the width of the contact area between the pontic and the retention arms, and over here, the height occlusogingivally of the contact areas. I cannot overemphasize that these should be as thick as possible. Today, again, I would restore these teeth with implants, not with the resin bridges, but at the time, with the materials we had available and with the technology, this was a treatment that was very successful for the patient, very successful for us as professionals, and it provided the patient with an excellent service. Here you can see it. From the occlusal, you can see the anatomy, you can see the aesthetics, very natural looking, and that's the two cases. Thank you.
Okay, fantastic. Very, very interesting. So I ask Octavian and all the attendees in the webinar to raise their questions and discuss these cases with George Freedman.
Okay, George, thank you for these examples. First of all, I want to say I agree with you, and I have a special lecture only for this. There is no aesthetics without function. This is basic of prosthetic restoration, for my opinion. Second one, I have a problem with resin restorations because the plaque accumulations is a lot higher than on ceramics, or nowadays even on zirconia. Of course, these are old cases, but resin is not my favorite. Another thing is I had bad experience with such inlay bridges. I had to took a lot of them out with necrosis of the pulp of one of the tooth, of the adhesins, or both of them, because if the doctor who made it doesn't look very well at the function, they usually came out very easy. So this is my contribution to your cases, which I think for that time was a very interesting and innovative solution with the hard core of this composite, I don't know if it was fiber, glass fiber, something like that.
It was glass fiber, yes.
And it was a good solution for that time. Nowadays, I wouldn't do this.
I agree.
And that's what I had to contribute to your case.
Thank you.
Okay, there is Maureen again, very active today. Please raise your question, Maureen.
First of all, I would like to say very nice presentation on the resin bonded bridges.
Thank you.
However, I would like to know the picture that you showed in which, I think it was afterwards when the patient had lost quite a lot of his teeth, but the resin bonded bridge was still there. It's amazing for me to see that, because I want to know how did the patient manage to maintain hygiene on those resin bonded bridges, as you cannot take your floss from the occlusal to the gingival margin of the teeth. There must be some food impaction, there must be some debris over there that the patient would not be able to get out. That's my only question. And the other question that I had, you answered in the end, that you would not go for resin bridges now and you would rather go for implants. But I would like to know, even then, the health of the gums around those teeth in which the resin bonded bridges were given was very good as compared to the adjacent teeth. How did the patient maintain his hygiene?
The first question. We, at that time, after treatment, I thought that, looking at the patient, that he would floss as much after treatment as he did before, which is not at all. So how do we get around that? And what I encouraged him to do is, within about 3 or 4 days after the resin, after the extraction and the placement of the resin bridge, we got him onto a device called a water pick. I don't know if you're familiar with that.
No, I'm not actually.
This is a home device that is used by patients. They simply fill it up with water, and it's a strong jet of water that is used to go in between the teeth. The same way as we dentists, when we finish everything, we spray air and water on the teeth and in between to dislodge debris. And the water pick, and it's W-A-T-E-R-P-I-K.
So it's a substitute to a toothpick, you're saying water pick.
It's not a substitute. It's not a substitute for flossing. It's what I call water flossing. It's for people who don't floss. Some of them might use the water pick effectively, and the water pick is actually more effective than floss is, surprisingly, in a number of studies, and more patients take to it than do to flossing. So we got the patient onto water pick, and he used it as often as he did. I can't tell you how often he did, but the tissues have remained relatively healthy. Most of the other teeth that you saw were super erupted and had minimal bone around them, so chances were that they weren't going to last, and at that point even water pick or flossing wouldn't be able to help them. So that was one question. So now the issue of bone. Let us say we have a lot of bone today in an area where we're trying to replace a single tooth. If we have a lot of bone, there's no question that we want to put an implant. Let us say there is, because of large periapical abscess, a total loss of bone on one tooth, but the 2 teeth on either side, the abutment teeth, do have some reasonable bone left. We then have to give the patient the opportunity to decide between bone grafting and implants, or an immediate result, such as this. In fact, what we can often do, and we do nowadays, is we do a resin bridge immediately for the aesthetics, temporary aesthetics, for approximately duration of 1 year or so, and then we do the bone graft And while it's healing, while the implant is placed, the patient is not walking around with a missing tooth. This is very important in anterior regions. So we can maintain the patient's aesthetics without a flipper denture, without a space between the teeth. In terms of maintenance, when a patient hasn't maintained their teeth before, chances are they're not going to maintain their teeth after. When we look at restorations like resin-bonded bridges or implants even, I don't think that we can be looking in some mouths for a lifetime service. We're looking for maintenance type of restoration dependent on the patient's contribution to their own oral health. If the patient is going to contribute to their oral health, that restoration is going to last a long, long time, and the temporary or provisional is going to be a very long time. If the patient doesn't contribute, it's going to fail quickly.
Thank you so much. Just another thing that I wanted to ask, you said you would give a resin bonded bridge on the anterior region while the patient's implants heal in an area where there's insufficient bone. My question is, after the implant gets osseointegrated and it's time to load the implant, first of all, when you remove the resin bonded bridge, isn't it going to affect the adjacent abutment teeth? And after that, after the removal of the resin bonded bridge, when you do load the implant, the adjacent teeth, do you then fill them up with composite, or what? I mean, why to even touch the adjacent teeth just to provide the patient with, I know it is a problem because the patient wouldn't want to move around having a single tooth missing from the anterior region, but then again, what's the use of giving an implant if you are touching the adjacent teeth or using them to give them a temporary resin bonded bridge?
You're absolutely right. In cases where there's an existing restoration in the abutment tooth or the adjacent tooth, we use the existing restoration without touching the natural tooth structure.
Okay.
In cases where those teeth are untouched, they're virgin teeth, no decay, no restoration, we simply bond this on to the lingual. Today's bonding materials, the adhesives are strong enough to bond on to enamel. We can bond on orthodontic brackets for years. So we can certainly bond on a retainer for a bridge like this for 6 or 12 months, and we don't touch the tooth. Now, when we remove that, we have to be very, very careful in removing the remaining resin once the implant is loaded so that we don't touch the enamel. And the secret there is, of course, magnification loupes, and we remove it with a very fine diamond, and then you dry it. When you dry it, you can see very easily the difference between the enamel, which is shiny, and the composite, which is dull. So you never ever have to remove it, and the final layers are often removed by a scaler, not by a diamond.
Okay, thank you so much.
Very welcome.
Okay, thank you very much. Was a great question, and you're very active today, Maureen. I appreciate it all very much. Now there's another question from Juan Gaston from Argentina. Juan, can you hear me? Juan? Okay, then I read his question to you, George.
Yes.
What cement did you choose for cementation, resin dual or trademark, and what trademark?
At that time, 15 years ago, I used a dual cure resin cement from Dentsply, from Dentsply caulk, which I believe is no longer on the market.
Okay.
However, any dual cure resin cement that is available on the market today would be fine. Now, there are dual cure resin ionomer cements. There are dual cure glass ionomer cements, and those are not good. We need a dual cure resin cement, straight resin cement. Okay. How can you tell a dual cure? Because a lot of companies claim that a product is dual cure when it is actually only light cured. The way to test these cements is to mix a very small batch, put it on a piece of, to put it on a pad, and not to light cure it. Within 6 or 7 minutes at the most, it should be cured. If it's not cured, it's not a dual cure cement. If it is cured in the absence of a curing light, it is a dual cured resin cement. So any commercially available dual cure resin cement, and you can test them to make sure that they work.
Okay. Thank you.
The bonding agent, by the way, that you use with these dual cure resin cements is a 5th generation or 4th generation resin cement, dental adhesive, and those are the multi-components where you etch the tooth, you bond the tooth, and they have a dual curing additive. The 4th generation adhesives are all dual cure. The 5th generations need to have a dual cure component.
Okay. Thank you. I guess this question is answered. Juan, if you do have another question, please raise it writtenly, because obviously your microphone doesn't work. There is Gurav who has a question. I tried to entitle him to speak. Gurav, can you hear me? No, you can't, obviously. Gurav questioned, just a second. Yes. Everstick fibers or Ribon fibers, which fibers were used? And the second question from Gurav is between Pontic and inlay. Obviously, that fits together.
Okay, so the first question, it's any of those can be used. This was the material that I actually used here was a glass material that was available from the United States. Ribond can also be used, and the other product that was mentioned can also be used. It's really not an issue which one you use. I'm not sure I understand the second question. This is really 2 inlays on the abutment retention teeth that are attached physically and chemically to a Pontic. I don't see how you can have it or.
Okay. Juan also added a question, do you use phosphoric acid?
Do I use orthophosphoric acid? When I'm using dual cure resin cements, and I use 4th or 5th generation adhesives, yes, I use what orthophosphoric 38% etching acid on the enamel surfaces. I try to keep them on the enamel surfaces. I'm sure some gets onto the dentin anyways. And the etching time is 15 seconds. The wash time is 5 seconds.
Okay. So Anis from Greece raised his hand. Anis, do you have a question?
Yes, I have a question.
Please raise it.
Two small ones, but yeah. Okay, I'll start with the first one. Mr. Freedman, thank you very much for your presentation. I wanted to ask something you mentioned before. You mentioned that in a certain number of cases, a water pick could be more effective than actual flossing. Now, I'm asking that because in my textbook and in my university, I'm still a student, it is the idea of a water pick is mentioned, but it says it doesn't remove plaques, so it's not actually something we should recommend. So I was more asking if you could share more details on in what kind of cases a water pick would work better than flossing, and if you have some articles that you could share. And the other thing is I'm going to mention both questions. Is if in the case of a first premolar, if we could use a Maryland bridge as a treatment solution, because we say Maryland bridge are usually for anterior teeth. So I'm wondering if in the case of first premolar we could do sort of an exception. Thank you.
Okay. Let me discuss the second question first. I was a great proponent of Maryland bridges, did hundreds of them. Nico, am I on, by the way? Hello?
You're
Hello?
always on. You're on.
I can hear
Yes.
you, but
Yeah, I'm always on. Okay, I didn't know. I heard some bumps. So anyways, let me answer the question about Maryland bridges. In the 1980s, I did hundreds of them. Most of them worked well for a number of years. They worked for about 3 to 5 years, and then they failed. And once they failed, they lasted less and less long until we could no longer use them. We eventually started adding retentive grooves on the abutment teeth and made them more successful, even in first molar and second molar areas. First molar and second bicuspid areas, and they were quite functional, but the resin-bonded bridges simply lasted longer and looked better. So that's why I went away from Maryland bridges. That was one. Now, the water pick I first heard about when I was in dental school, I guess 40 years ago, and it was dismissed as a toy. I thought of it in that fashion until 2011. 2011, I saw one and then several publications on the efficacy of the water pick and its comparison to floss in terms of removing plaque and debris from the tooth structure. Now, floss will work on the mesial and distal interproximally, but it doesn't work on the buccal and lingual. The water pick does work on the buccal and lingual and works interproximally as well. When I first saw those studies, I acquired a unit and did a very unscientific personal test. What I did first was I would floss my teeth and then water pick after to see if there was any debris that came out, my own mouth. Like I said, this wasn't very scientific. And after flossing, I found that the water pick could remove debris from my mouth, visible debris. Then I tried it the other way around. I water picked first, and then I flossed to see if the floss would remove debris that the water pick missed. And I could see no visible debris. What we tell our patients today is if you want to get the interproximal and the buccal and lingual surfaces, you need to use both. What we find is that patients respond more positively to water pick than they do to floss. Typically, and we have very motivated patients, if I told you that 5% of our patients floss regularly, then I'm deceiving both you and myself because I don't think it's anywhere near 5% who will floss regularly in between appointments. We certainly try to push it. We've been pushing it all the time. We've mentioned it every single time, but people just don't do it. They find it cumbersome. More people react positively to water picking, and for that reason, I'll use anything that I can get, and I'll do any trick that I can find that will help my patients improve their oral hygiene. Now, I don't have that study with me, but I can send it to Nico, and Nico, you can post it. The original 2011 study and all the other studies, I can probably get it to you over the weekend, so you'll have it by Monday.
Okay, no problem. I will forward it to Anis. It would be a great pleasure for me to do so.
And you might also want to put it online for all the other people who are listening in.
Absolutely.
That was a very useful comment on the efficacy of water picks, because exactly what you said you saw when you were in dental school, I think we are taught the same thing, you know.
Yeah.
It's good to see how things are being reviewed and being made more practical for the people to use.
Correct.
Okay. So I guess we came to an end. Thank you very much for attending this second DoooX roundtable. I especially thank to Octavian and George, but also to Anam, Anis, Gurav, Jacqueline, Jörg, Juan, Marine, and Samar, and also Ian. And the next roundtable will be at the end of February. The topic is not quite clear yet. And I also want to announce that we will start at the end of February our first e-certificate course in aesthetics with the course director George Freedman, which will lead in the second part to an MSc. So if you do have any questions or inquiries or great ideas also concerning topics, please let me know. You all got my email and you can easily contact me either on Skype or on Facebook. So have a great weekend. Thanks a lot again. And it was great having you here. Thank you very much. Bye-bye.
Bye.
Thank you, and
Thank you.
see you soon.
Okay. Bye.
Bye.
Bye.